Okay, so just to bring you up to speed on our preparations for winter, maybe to set it in context. At the moment, as far as our performance is concerned, for the month of October, we delivered just above 90%, which was certainly an improvement. Our year-to-date performance, we're holding it just above 90 as well. November is starting to look more difficult. We've had a cold spell. We've got a lot of respiratory issues, especially amongst children, so we've started to see a deterioration. If we look at some of our other metrics, DTOC, we are doing a little better on it, down to about 4.6%. This time last year we were as high as I think about 5.8%. We've managed to free up the equivalent of about 1,000 beds from the work that's taking place with our social care colleagues and also our health DTOC. We still have some way to go. Our bed occupancy is still very high and clearly rising as the days go by. So that's the sort of activity context, and we can go into that in more detail in questions. So a little bit about how we've prepared. I suppose preparation for winter started last winter, and all the work that we've been doing on urgent and emergency care during the year comes into play at this stage. Two different things to talk about very briefly. First of all, the transformation work. I think I've previously said to the board that it is very important that this year we continue to focus on transformation during the peak of winter, because what we don't want to do is to have that break we had last year and come along in April and say, well, have we made sufficient progress on areas like 111, implementation of the ambulance work, etc., etc. So a determination that we will continue, and I think that's important because as we go into this winter we can see the progress that we've achieved since last winter. So I think our decision earlier in the year, and indeed last year, that transformation had to have a very high profile is absolutely right, and hopefully we'll be sitting here this time next year with even more progress. But just to mention a couple of areas that are significantly different to last year. I mentioned 111. Last winter we had about 22% of people who contacted 111 had a clinical contact. This year already we're up to over 37%. So that's a significant improvement. As far as our ambulance programme is concerned, over the course of the last year, we've been able to agree the new standards as far as how the service delivers, and by December, all of our ambulance trusts throughout the country, with the exception of the Isle of Wight, will be in the process of delivering those new standards, which simply frees up an awful lot of ambulance capacity. So that's very important. As far as what is out there in the community, what people see on a day-to-day basis around urgent treatment centres, walk-in clinics, etc. We've spent a lot of time in the last year talking about how confusing that is and that we need to make a standardised offer. By the beginning of December, approximately 106 facilities nationally will be providing that offer. Yes, we still have another 250 plus to go, but we're well on the road as far as that is concerned. And as I mentioned a few minutes ago, for the first time we've started to see this reduction taking place in DTOC as far as people who are in hospital who shouldn't really be there are concerned. So they're all part of the transformation work, and during the winter period, at a local level, at a regional level, at a national level, it is our intention that this work will continue and that in the coming months we'll be able to continue reporting improvement. So the second part of our work is very much focusing on the operational delivery on a day-to-day basis at a local level, a regional level, national level. A number of months ago, the board heard from us how we reviewed the work that had taken place last winter, and the arrangements that we have put in place for this winter is learning from that. The focus this winter is on supporting people at the front line, all hospital systems having local escalation plans, local delivery plans, and trust boards, CCG boards, all of the other stakeholders coming together in recent months to talk about how they can deliver during the period of increased activity. So the local escalation plan is sort of the core of all of our planning. To support that at a regional level, we have put in place an architecture whereby there's a permanent winter director and a team of people working there, and their job is to support people when they feel at a local level that their own escalation plan isn't sufficient to overcome some of the day-to-day difficulties, and at a national level having a 24/7 winter room running, again to support our regional colleagues and then locally. I think one of the things that people in the service had said to us last year was that indeed last year and in the years before that, their sense was that when things became difficult, both at a regional and a national level, what we tended to do was ask for information rather than provide support. So the whole culture for this year is very much around if somebody feels they need support at a local level, and we have a named team of people working locally, that they then contact the regional winter room working alongside the national room, and that the purpose of the arrangement is, yes, to have continuous monitoring, but to really support intervention. Our colleagues from PHE are working with us within the National Winter Room as well, and a key aspect of this winter is going to be getting real information out to people at the front line in a timely manner, and translating some of the excellent work that PHE do so as people can see what's coming down the tracks. You know, what is the meaning of cold weather from an attendance point of view, 5 days hence, etc., etc. So those two things running side by side, our operational arrangements and our transformation work continuing. So I think in conclusion, I would suggest that we are definitely better prepared for this winter than we have been for previous winters. My final comment would be to say that we've got two concerns, and I don't think anybody will be surprised by that. First of all, it's too early for us to say the impact that flu will have. We have ensured that flu plans are very much part of our local escalation plans, and we are working right across the system in preparing for the worst, but hoping that that won't be the case. But we are a few weeks away from being able to say with any certainty where we might be. And then the other issue will be overall capacity. Because of the monies that have been made available, and we are doing an intensive piece of work this week and into early next week, looking at how we can best utilise those resources at a local level to support the work that's already been done. But I think we are all aware that at the end of the day we have a finite amount of capacity, and that is very much dependent on, in particular, our nursing levels, certainly our medical levels and other staff as well. But I think our nursing levels will be a real determining factor around the number of beds that we can safely provide in the system. So I think they're the headlines from me. Happy to answer questions.
Richard?
A couple of questions, Polly. One on the transformation stuff and one on the operation stuff. Actually, a specific one on transformations. One, it's around the 111 and the increased contact from 22% to 37%. Has that had any impact?
Yes. So from the early information that we have, what we are seeing is there's variation across the system. But as far as the number of people who actually contact 111, who then become attendances at our A&E departments, we're somewhere around 8%. But in areas where we have seen a real sort of increase in the clinical contacts, we're falling to as low as 6%. Also, a lot of the information that we are receiving back from individual services around patient satisfaction seems to suggest that it's giving a new confidence in the 111 service to users. Now, clearly it hasn't been rolled out to that level across the whole, and we are aiming to get to 50, but I think we're moving in the right direction.
But it's demonstrating value.
Yes.
So it's working.
Yeah.
Yes, it's
absolutely. Yeah.
And on the operational stuff, I know it's really early in the year, yeah, and as you said so about the flu. Has any of the system actually been tested in anger on anything yet, or is it too early? So is there anything where we've gone from local escalation to regional, potentially to national, and how's that worked?
Yes. Well, I think what we have been doing for about a month now is really running these arrangements on a daily basis. So we haven't been running them 24/7, but we've established each component part, and we've been working as if we are in the middle of winter. So we're actually testing them every day of the week. So we would be very much aware of what's happening at a local level, going through all of the arrangements.
And the testing's showing they're working?
Yes, and so far the feedback is mixed as far as information going up and down the system is concerned. Being completely honest, we have got parts of the country who still feel that they're being asked for various bits of information. That's certainly at a national level and a regional level. We are saying, no, that's not the culture for this year. But it's work in progress, and we are tracking it through. And in all honesty, most of the time, or most of the occasions when that has happened, when we've investigated it, it's being done with the best of goodwill, because it's people wanting to be able to understand what is happening locally, etc.
Pauline, fantastic again. Could you tell us by now, you should know, what was the flu vaccination uptake? Did it meet your target, number one? Yeah, go ahead.
Right. So I think the first thing to say is two different figures, etc. So first of all, from a staff point of view, we've started to receive the information, and it looks as if the uptake at this point in the year is better than last year. But there's variation across the system. So we have some organisations that have achieved 100%, but we have some organisations, in particular some of our community organisations, that are really still in the 30s. But overall, higher than this time last year. As far as our population is concerned, at the end of month 6, again, we were in a better position than this time last year for older people, for children, for pregnant women. So I think year on year we're seeing success.
The second question was, you're doing this fantastically well, and I just wondered whether you're keeping in your scope of thinking that we need to get the balance right between all what we're doing here, not negatively impacting elective care, and how we get that message down to the providers. This is very, very important, but that doesn't mean you do it at the expense of the other.
Yes, yeah. So we've had some very helpful meetings with the college and with the president, with the academy, with the presidents of all of the colleges, and I think the agreement that we reached there, if that's the appropriate term, is that whatever we do, we need to do it in a planned way. And as part of our local escalation plans, what we are saying to every hospital system is we need you to also look at your elective work. And we need you to be able to ensure that you are doing your 62-day cancer work, that you're maximising the amount of day case work, that you are doing your urgent patients, etc. And we want you to plan, because what we don't want are these ad hoc cancellations on the day. And we're stressing the need to look at the whole quarter, not just to look at that Christmas period. And also, you know, and I know that it's early days, saying to people that if you are cancelling elective work, it needs to be done in the best possible way, and you also need to think about how you are going to recover from that. So as you can give not just a message to the patient, but to all of the staff who are involved.
Good.
I wanted to just check my understanding of, in the transformation area, the ambulance response program and the related 111 thing. Am I right to think that part of this is the idea that not only will people be encouraged to obviously call NHS 111 and there get to speak to a clinician of some kind rather than somebody just using software, but that it's also part of it that that part of the 999 stream which can safely be streamed over to 111 is streamed in that way in real time. Is that the case? And then I have a next question depending on the answer.
Okay, so just to really explain that, I think the first thing to say is that our medium-term vision is to try and encourage everybody who needs urgent or emergency care, unless it's in an absolutely life-threatening situation, to dial 111, because then that gives us the ability to link the person's needs to the most appropriate service. And indeed, sometimes that might actually be that we would link it back to 999. At the moment, we have got certain constraints as to what we can do with 999 calls. The new standards that we've put in place is giving us more time to decide what our response can be, i.e. do we send a paramedic, do we send a blue light, etc., etc. And that's really important, and you know, we've set out in the paper the amount of ambulances that it's freeing up. And what we're not able to do right now is, if you phone 999, us transfer you to 111, but this is all part of our future thinking. In some parts of the country, the 999 and the 111 provider are actually the same, so we're making increased progress, but across the country we're not able
Well, that was sort of the following question I had was, how prevalent is it? Because in some parts of the country, that possibility existed precisely because the two were run under the same roof. What proportion now have the ability to, in a clinically safe way, direct those calls from an initial 999 call into a 111 situation?
So that, in essence, we are not really able to do that at the moment if the call comes in as a 999 call.
Not at national level, but
not at a national level. I can't tell you the number that may be able to do that locally, but I can report it back to the board.
That would
I
be
need
very
to look at the
interesting.
procurement of each of the services, so I can't tell you.
Okay.
Just a couple of points. Pauline, I recognise I need to do more to support on the clinical support you're having in the ops room, but I'm spending the day next Wednesday in the ops room all day, so I shall no doubt learn lots about what we need to do to support. On your point about nurse vacancies and the potential risk of capacity, yes, it's a very real risk. There are nurse vacancies. Directors of nursing and boards are making decisions day by day to making sure that they can staff their wards. It's not just about hospital wards though. It is about making sure we've got sufficient staff in the community teams in order to take patients from hospitals into communities. So I just wanted to flag with this board that it is a very real risk of the impact on our TT as boards are making decisions to provide safe care for patients in our organisations. And I guess that's why NHSI is doing the work it's doing on retention, because looking after and keeping the staff we've got is a vital piece, so that we can making sure then we've got enough staff to do all of the care, whether it's through emergency or the elective pathway. So the retention work that we're doing is vital for supporting you in your work.
Indeed.
Could I just follow up on one of Emma's questions? Sorry, 'cause it just prompted me. It's about the impact of the elective work, and whether there's any data coming through on cancellations that tell us anything about what may be happening out there?
Yeah, the short answer is no, but through these calls that we are doing, and as I mentioned over the course of this week and next week, I will have essentially a chance to speak to every chief exec and every accountable officer for a CCG in the country. And I suppose one of the heartwarming things that's coming out of those calls is how hard people are working to try and ensure that they don't have to cancel their elective work. The schemes they're putting in place, the arrangements, but what we are actually saying back to them is fully encouraging that, but if they believe that they will need to cancel, we want to get that information in. So we haven't got it at our fingertips at the moment, but I think we're probably about 2 weeks away from having a good picture nationally, all of the RDs working with their hospitals.
Okay.
Pauline, is it fair to say that speed really is of the essence in these calls that you're making, in us sort of really locking down people's plans so they have the best possible chance of implementing them well? So if I have a worry, it is that, you know, come from outside the system, this is mighty late to be allocating new money and people locking down new activity, and we really need to get these decisions made quickly to give people a fighting chance of being able to succeed.
Yeah, like I think from the calls we've done already, it would be fair to say that about half of the things that people are proposing that they would do, they're already really doing at risk. So we're
Okay.
working
Well, in
very
some
hard
ways that's
with this.
perversely reassuring.
Yeah.
Practically, it means they're on the ground doing the right things for their communities.
Yeah.
Clearly, the budget was when the budget was.
Yeah.
But also, interestingly, as far as the beds that people are identifying out of hospital, they are coming with very well worked up plans and able to tell us, you know, when they will be able to secure these beds, etc. So I think a lot of pre-budget preparation took place, but that's really useful to us. But we would hope that by the middle of next week to be in a position to clarify to every hospital and the wider system where they will stand as far as this support is concerned, and some of that is happening informally in between.
Well, if
But
there's
we
anything,
we did encourage people to actually go ahead and do stuff at risk
And
while
to
we
come up with plans.
while we scrapped about the money. So there's a little bit of this you would have expected, because we were saying we were going to try and get some extra money into the system.
They are very well prepared.
If there is anything that you need, Pauline,
Yes.
from any of us to unblock anything, to make sure that we do give sort of system clarity quickly, then you should absolutely let us know. Well done.
Thank you.
Excellent.